All right, let's talk about one of the most fundamental skills you've got to master as a medical trainee, reading an ECG. We're going to peel back the layers on those squiggly lines so you can see them for what they truly are, a detailed story about the heart's electrical journey. Let's dive in.
You know, when you first get handed an ECG, it can look like just a bunch of chaotic scribbles on a page. But it's not at all. It's a super detailed narrative, a beat-by-beat story of the heart's function. The real key is just learning the language, and that's exactly what we're going to do right now.
So here's how we'll break it down. First, we'll get into what an ECG actually is. Then we'll follow the heart's electrical impulse from start to finish. After that, we'll look at how we capture that signal, learn to decode the individual waves and squiggles, and finally, put it all together to see what a normal ECG is supposed to look like.
Okay, so let's start at square one. What is this test, this graphical record, fundamentally showing us?
At its absolute core, an ECG is just a graph. That's it. It's recording the tiny little bits of electricity, the electric potentials, that the heart's muscle fibers generate every single time it beats. We pick up these signals with electrodes on the skin, we amplify them, and we print them out as that tracing you're so familiar with. Now, to understand the graph, you first have to understand the orchestra that's producing the music. And that, my friends, is the heart's very own electrical conduction system.
It all kicks off in the sinoatrial node. That's the heart's natural pacemaker. From there, an electrical wave shoots across the atria, making them contract. Then, the signal hits a little speed bump at the AV node, pausing just long enough for the ventricles to fill with blood. Then, whoosh, it travels super fast down the bundle branches and out through the Purkinje fibers to trigger that big, powerful contraction of the ventricles. That whole sequence, that's one heartbeat.
Now here's a really important distinction to make. The ECG doesn't actually see those specialized pacemaker cells we just talked about. Nope, it only records the electrical buzz from the main working heart muscle, the myocardium, as it contracts or depolarizes and then resets itself or repolarizes. It's all about the big muscle groups.
So how do we actually record this incredible electrical symphony? Well, that's where the leads come in. And honestly, the best way to think about them is like setting up a bunch of different cameras to view the heart from all angles.
Let's clear up something that trips a lot of people up. The electrode, that's the sticky patch you actually put on the patient's skin. A lead, though, that's the view you get. It's the perspective you get by measuring the difference in electricity between two of those sticky patches. So think of it this way. An electrode is a point. A lead is a perspective.
And these leads, these different perspectives, they come in two main flavors. You've got your bipolar leads, like leads I, 2, and 3, which measure the electrical difference between two specific spots on the body. Then you have unipolar leads, which is pretty much all the others, and they measure the difference between one spot and a central calculated reference point.
A standard ECG gives us 12 of these views, these camera angles. 6 of them are the limb leads, and they look at the heart's electricity from the frontal plane, kind of like you're looking at the patient straight on. The other 6 are the chest leads, and they give us a cross-sectional view, looking at the heart from the horizontal plane. You put them all together, and you get a really nice 3D picture of what's happening.
And this quote just nails it, right? All 12 leads are watching the exact same event, a single heartbeat, but each one is seeing it from its own unique angle. That's why the tracing looks different in each lead. An electrical wave moving towards one camera might be moving away from another.
Okay, this is it. This is probably the single most important rule of reading ECGs. If you get this, you're halfway there. If that main electrical signal, the wave of depolarization, is moving toward a lead's camera, the line on the paper goes up. We call that a positive deflection. If that wave is moving away from the camera, the line goes down. It really is that simple.
All right, we've got the big picture down. We know how the signal is generated and how we record it. Now let's zoom in on the tracing itself and start learning the alphabet and the grammar of the heart's language.
Every single heartbeat is basically written with 3 main letters. First up is the small P wave. That's the atria contracting. Then you get the big spiky QRS complex. That's the powerful squeeze of the ventricles. And finally, you have the T wave, which shows the ventricles resetting or repolarizing, just getting ready for the next beat. P, QRS, T.
Now, it's not just about the shape of the waves. The timing between them is absolutely critical. The PR interval tells you how long it takes for the signal to get from the atria to the ventricles. The QRS duration tells you how fast the ventricles are depolarizing. And the QTC, well, that measures the total time for the ventricles to fire and then fully reset. You've just got to know these normal values. They are essential. So how in the world do we measure those intervals? Easy. We use the grid on the ECG paper itself. At the standard speed, each tiny 1 millimeter box represents exactly 0.04 seconds of time. So a normal PR interval, which should be about 0.20 seconds, shouldn't be any wider than 5 of those small boxes. That grid, that's your ruler.
So we have the pathway, we've got our caras, and we know the alphabet. Now, for our final section, let's put all of these pieces together and see what a normal, healthy ECG actually looks like on the page.
One of the key features you want to look for in a normal ECG is something called R-wave progression. It's simple. In those chest leads, as you move your camera from V1 on the right side of the chest over to V6 on the left, that main positive spike, the R wave, it should get taller and taller. This just shows that the main electrical force of the heart is pointing down and to the left, exactly where it should be.
All right, now for a concept that honestly trips a lot of people up, the electrical axis. It sounds complicated, but it's just the overall direction of the heart's electricity. And guess what? There's a super fast, simple way to check if it's normal. Step 1, just look at the QRS complex in lead I. Is it mostly pointing up? Is it positive?
And step 2 is just as easy. Now do the same thing for lead 2. Look at that QRS complex. Is it also mostly positive, pointing up?
And here's the payoff. If the QRS is positive, pointing up in both lead I and lead 2, you have a normal axis. Boom, it's that easy. If I is up but 2 is down, that's left axis deviation. If I is down but 2 is up, that's right axis deviation. Seriously, this 2-lead check will give you the right answer almost every single time.
So let's bring this all home. A normal ECG isn't some big mystery. It is a highly predictable story. It's the story of one electrical impulse, traveling along a very specific path, being told to you from 12 consistent camera angles. And once you know what that normal story is supposed to look like, you can immediately spot when the plot takes a wrong turn. We started this by saying an ECG tells a story. Well, now you know the alphabet. You know the grammar. You know the basic plot of a healthy heart. Your job, from this point on, is to take this foundation and start reading the thousands of unique, incredible, and sometimes scary cardiac stories you're going to encounter in your career. So, what stories will you uncover?